Thyroid gland anatomy. The thyroid gland is an H-shaped or butterfly-shaped gland located in the lower neck, in front of the trachea, between the carotid arteries. It's formed of two loops connected to each other by the isthmus. Normal weight about 10 to 25 grams, attached to the thyroid cartilage and to the upper end of trachea, so it moves with swallowing. Biosynthesis of thyroid hormones, trapping, binding, coupling, and release. Iodine trapping, iodine uptake by the thyroid gland. Binding, tyrosine bind to iodine to form mono and diiodotyrosine. Coupling, two molecules of diiodotyrosine, T4, thyroxine, 80 mcg per day. Mono plus diiodotyrosine, T3, triiodothyronine, 4 mcg per day. T4 is converted to T3 in the peripheral tissue. 20% of T3 is produced by the thyroid gland, while 80% of T3 is a result of breakdown of T4 peripherally. Release. T4 and T4 release under the control of TSH, thyroid stimulating hormone. Thyroid hormones circulate in two forms: protein-bound, mainly thyroxine binding globulin, more than 99%, free part, active part. 0.03% of total serum T4 is free, and 0.3% of total serum T3 is free. T3 is from 3 to 8 more potent than T4, and it acts more rapidly. Half-life of T3 is 24 hours, while the half-life of T4 is about 1 week. Thyroid diseases. Causes of hyperthyroidism or thyrotoxicosis. Toxic diffuse goiter, the most common cause of hyperthyroidism. Graves' disease in the USA, Bestos disease in Europe. Toxic multinodular goiter. Toxic salivary adenoma. Excess production of TSH by pituitary tumor, very rare. Hashimoto's thyroiditis with transient hyperthyroid phase. Extrathyroid source of hormone, thyrotoxicosis fastigia. Exogenous intake of thyroxine or ectopic thyroid tissue, stroma ovarii. Iatrogenic immudarone. Classification of hypothyroidism according to the age of onset: cretinism during infancy, juvenile myxedema before puberty, myxedema after puberty. According to the site of the cause: primary hypothyroidism, the cause in the thyroid gland; secondary, pituitary gland; tertiary, in the hypothalamus. Primary thyrotoxicosis or Graves' disease. It is the most common cause of hyperthyroidism. Autoimmune disorder consisting of hyperthyroidism plus one or more of the following triad: painless diffuse goiter 90%, ophthalmopathy 60%, dermopathy 2%. Physiology: hormone T3, triiodothyronine, and T4, thyroxine. Gland, thyroid gland. Function of the hormone: hormone of metabolism and development, stimulates physical, mental, and sexual growth, increases energy production and oxygen consumption, increases glucose absorption and uptake by the cells, decreases cholesterol and prolactin levels, increases respiratory and heart rate, stimulates erythropoietin, increases the tissue responsiveness to catecholamines, hepatic conversion of creatine to vitamin A. Regulation of this hormone by thyroid stimulating hormone and TRH. Etiology: autoimmune disorder characterized by a variety of circulatory antibodies, thyroid stimulating immunoglobulin or TSI/TSH receptor antibody. They bind to and activate the thyroid TSH receptors, may be associated with other autoimmune disorders, autoimmune polyglandular syndrome. Clinical picture: from 30 to 40 years, most commonly in females. Clinical picture of the cause: association of autoimmune diseases, polyglandular autoimmune syndrome 2, type 1 diabetes mellitus with adrenal failure, and Graves' disease. Patients with Graves' disease often have more marked symptoms than patients with thyrotoxicosis from other causes. Clinical picture of the hormone: general, polyphagia with loss of weight, intolerance to hot weather, progressive muscle weakness, bone, pain, pathological fracture due to bone calcium turnover. GIT, increased appetite with loss of weight, diarrhea, and just palpable spleen. Gentle, for females amenorrhea, for males impotence with gynecomastia. Cutaneous, skin is thin, warm, flushed with generalized sweating. Hair, fine and thin. Nails, onycholysis and thyroid acropathy, which is a rare complication of autoimmune thyroid disease. Clinically, it presents as nail clubbing, swelling of digits and toes. Peritibial myxedema 2 to 3%, dermopathy, irregular, non-pitting, mildly pruritic, orange peel-like thickening of the skin along the interior aspects of the shins of the tibia, usually symmetrical due to deposition of mucopolysaccharide substance in the subcutaneous tissue. Cardiovascular system, more common in older patients, while the CNS more common in younger patients. For the cardiovascular system, pulse increased rate. The sleeping pulse rate is usually more than 100 beats per minute. Rhythm may be irregular due to atrial fibrillation or extrasystole. Character, water hammer pulse due to big pulse volume. Equality, unequal on both sides from retrosternal goiter. Thyroid function tests are mandatory in any patient with atrial fibrillation. Heart, hyperdynamic circulation leads to volume overload, leads to cardiac enlargement, then heart failure. Blood pressure, systolic, it's elevated, isolated systolic hypertension. Diastolic, it's decreased, thyroxine leads to vasodilatation, so we have big pulse volume. CNS, as we mentioned, more common in younger patients. Psychic, nervousness, anxiety, agitation, insomnia, and finally mental disturbance. Organic, fine tremors in tongue and hands. Brisk, deep tendon reflexes. Thyrotoxicosis can cause the muscle fibers to break down too quickly, causing brisk reflexes. Polyneuropathy, myopathy, and finally myasthenia. It's important to know that elderly patients with hyperthyroidism may be apathetic rather than nervous. So we have apathetic thyrotoxicosis. For the eye, we have exophthalmos and certain eye signs. Exophthalmos bilaterally, but it starts unilateral, may occur even before the appearance of thyrotoxicosis. Etiology, oversecretion of autoantibody. Cold exophthalmos producing substance leads to lymphocytic infiltration of retrobulbar tissue and extrinsic muscles. Orbital pain and photophobia may occur. Blindness may occur secondary to corneal ulcers or optic nerve compression. Certain eye signs, DR, must be very simple. Dalrymple's sign, lid retraction. Rim of the sclera is seen between the cornea and upper lid. Dalrymple, LR, lid retraction. Rosenbach sign, fine tremors of eyelids on slight closure of the eye. Mobius sign, lack of convergence due to weak medial recti muscles. Von Graff's sign, lid lag on looking down. And finally, Stelvag sign, infrequent blinking. Ocular manifestations may be divided into two types, infiltrative and non-infiltrative. Infiltrative ophthalmopathy, mechanical due to accumulation of autoantibodies specific to Graves' disease, exophthalmos, and Mobius sign. Non-infiltrative ophthalmopathy due to increased thyroxine, lid lag, lid retraction, Stelvag, Rosenbach sign, occurs with any thyrotoxicosis, not specific to Graves' disease. Gland inspection, mild to moderate enlargement of the gland. Palpitation, consistency, fleshy or firm, surface, smooth. Percussion, dullness over manubrium sterni in retrosternal extension. Auscultation, systolic bruit may be heard due to high vascularity. Thyrotoxic crisis or thyroid storm, extreme form of thyrotoxicosis with mortality 10%. It's rare, life-threatening endocrinal emergency. Precipitating factors, surgery, parturition, acute illness, myocardial infarction, stroke, infection, discontinuation of antithyroid drugs. Clinical picture, severe manifestations of thyrotoxicosis including general fever with temperature more than 41 degrees Celsius, marked weakness, cardiovascular, severe tachycardia, hypotension, acute heart failure, and atrial fibrillation, CNS tremors, marked irritability, confusion, and coma, diarrhea, abdominal pain, hepatomegaly with mild jaundice, and for the treatment we're going to discuss it later. Differential diagnosis, neurosis, cold hand, normal sleeping pulse, increased appetite with loss of weight, diabetes and parasitic infections, hyperdynamic circulation, and finally muscle diseases, myopathy, and myasthenia gravis. Difference between primary and secondary thyrotoxicosis. Primary Graves, secondary toxic multinodular goiter, primary autoimmune cause, and age of onset from 30 to 50 years. Thyroid gland is diffusely enlarged. Cardiovascular manifestations are mild, while the CNS are severe. Exophthalmos is present and treatment is usually medical, while the secondary thyrotoxicosis, toxic multinodular goiter, and the cause on top of nodular goiter, age of onset 50 years, thyroid gland is nodular, cardiovascular manifestations are severe while CNS are mild, exophthalmos is absent while treatment is usually surgical. Monosymptomatic cases, when one of the manifestations of thyrotoxicosis predominates, such as thyrocardia, cardiac symptoms only, atrial fibrillation. Investigations, thyroid function tests, investigations for the cause, TSH level, normally is from 0.5 to 5 per liter. It's the most sensitive test of thyroid function, decreased in most cases of thyrotoxicosis by negative feedback mechanism, increased only in TSH producing pituitary tumor, which is very rare. Subclinical hyperthyroidism, defined as low TSH level with normal free T3 and T4 levels and associated with no or minimal clinical symptoms of thyrotoxicosis. Imaging of the gland, we have thyroid scan and ultrasound. Thyroid scan, radioactive nuclear medicine studies. Hot nodule, this tissue is rarely malignant. Cold nodule may be malignant in about 10%. Ultrasound indicates especially in cold solitary nodule. Cystic, benign, and solid malignant, we do needle aspiration biopsy. Fine needle biopsy, very small needle is introduced into the nodule and cells are aspirated for study. Thyroid receptor antibodies, TSH receptor antibody, thyroid stimulating immunoglobulin, antithyroid peroxidase antibody. Serum thyroglobulin and calcitonin levels are used as tumor markers when observing patients treated for differentiated and medullary thyroid cancers. And we have assay of hormone level. Total T3 and total T4 are increased, but they are not accurate. The most important one is a free T3, free T4. But free T4 is difficult to be measured, so we use T3 resin uptake with total T4 to measure the free thyroxine index. And we have T3 resin uptake, and all of those are elevated in thyrotoxicosis. T3 and T4 are over 95% protein bound to thyroxine binding globulin. So increased thyroxine binding globulin as in pregnancy increases total T3 and T4, but free T3 and T4 are normal. Decreased thyroxine binding globulin as in liver cirrhosis and nephrotic syndrome leads to decreased total T3 and total T4, but free T3 and T4 are normal. Investigations for the function of the hormone. For blood, we have lag sugar curve, increased calcium, calcitonin in medullary carcinoma, and decreased cholesterol, urine, polyuria, and increased glucose. Suppression test material, we use T3. Normally, it leads to decreased radioactive iodine uptake. In thyrotoxicosis, no effect. Treatment is divided into medical, surgical, and radioactive iodine. Medical indications are primary thyrotoxicosis, secondary cases, pre-medication before operation, treatment of complications and pregnancy. Contraindications are huge goiter, retrosternal goiter, suspicion of malignancy. Lines of medical treatment, beta blockers, antithyroid drugs. Beta blockers, propranolol, it provides rapid symptomatic control, tachycardia, tremors, and heat intolerance. It also decreases peripheral conversion of T3 to T4. Calcium channel blockers, verapamil and deltism, can be used for the same purposes when beta blockers are contraindicated. Antithyroid drugs, such as methimazole, propylthiouracil, and carbimazole. Duration from 1 to 2 years until thyroid hormones stores are depleted. Mechanism: these drugs inhibit the formation and coupling of iodotyroxines in thyroglobulin. Propylthiouracil, it also inhibits peripheral conversion of T4 to T3. Side effects: allergy 1 to 5%, fever, rash, arthralgia. Agranulocytosis 0.5%, usually presents with fever, pharyngitis. Treatment: stop the drug, fresh blood, cortisone, granulocyte colony stimulating factor, filgrastim, increases white blood cells. Hypothyroidism, increased TSH, leads to goiter. Relapse on sudden stoppage, severe liver injury, and acute liver failure with propylthiouracil. Radioactive iodine, oral single dose, iodine 131. Once it's concentrated in the gland after oral administration, it destroys thyroid tissue and controls hyperthyroidism within 1 to 2 months. Indications: failure of medical treatment, patient unfit for surgery, recurrence after thyroidectomy, and toxic adenoma. Contraindications: huge goiter, retrosternal goiter, progressive exophthalmos during pregnancy, lactation, and childhood. Side effects: post-ablative hypothyroidism, bone marrow depression, fetal anomalies if taken in pregnancy, and increased incidence of malignancy, so they are not given in childhood. Precautions: it's important to stop antithyroid drugs 4 days before and 4 days after the radioactive iodine therapy because it prevents radioactive iodine uptake by the gland. Surgical: subtotal thyroidectomy. Indications: secondary thyrotoxicosis, failure of medical treatment, huge or retrosternal goiter, suspicion of malignancy, pregnant women not responding to drugs. Preoperative preparations: antithyroid drugs lead to euthyroid state. Lugos iodine decreases the size and vascularity of the gland. Complications: laryngeal nerve palsy, hypothyroidism, hypocalcemia due to removal of the parathyroid gland. Choice of treatment: toxic nodule, surgery, or radioiodine treatment is appropriate. Resection is easy, certain, and without morbidity. Recurrent thyrotoxicosis after surgery. In general, radioiodine is the treatment of choice. Antithyroid drugs may be used in young women intending to have children. Further surgery has little place. Toxic nodular goiter is large and uncomfortable, enlarged with antithyroid drugs. Large goiters should be treated surgically because they don't respond as well or as rapidly to radioiodine or antithyroid drugs as diffuse toxic goiter. Diffuse toxic goiter in patients over 45 years, radioiodine is appropriate. In those under 45 years, surgery for the large goiter and antithyroid drugs or radioiodine for the small goiter is recommended. Treatment of complications. Ocular complications, heart failure and pretibial myxedema. Heart failure, bed rest, salt restriction, digitalis and diuretics. Persistence of atrial fibrillation, digitalis or DC shock. Ocular complications, protect the eye by ointment, sunglasses, methylcellulose, prednisolone to decrease lymphocytic infiltration. Radiotherapy of the orbit, orbital decompression. Pretibial myxedema, it remits spontaneously after a month or years. Local betamethasone cream relieves pruritus. Treatment of thyrotoxic crisis, propranolol in full dose started immediately for tachycardia. It blocks the peripheral effects of thyroid hormone. It also prevents the peripheral conversion of T4 to T3. The effects are dramatic and results may be seen within 10 minutes. Propylthiouracil remains the drug of choice in thyroid storm because its additional benefit in inhibition of peripheral conversion of T4 to T3. The dosage, 600 loading dose, then 200 mg per 6 hours orally, rectally, or nasogastric tube. Clinical effects may appear within 1 hour. Potassium iodide, Lugol's iodine, it decreases thyroxine release from thyroid gland. Hydrocortisone, 100 mg per 8 hours IV or IM to correct hypotension. Thyrotoxic crisis increases cortisol metabolism, relative adrenal insufficiency, refractory hypotension. Hydrocortisone corrects this hypotension. Also, steroids prevent peripheral conversion of T4 to T3. Treatment of precipitating factor, antibiotics for infections. Symptomatic treatment, dehydration, IV fluids, hyperthermia, ice bags, paracetamol. Aspirin should be avoided as it decreases protein binding with subsequent increase in free T3 and T4. Later on, restoration of euthyroid state may take up to 8 weeks. Thyrotoxicosis in pregnancy, medical treatment, propylthiouracil. Carbimazole not preferred because it crosses placenta and may cause congenital defects, including aplasia cutis of the neonate. Radioactive iodine absolutely contraindicated because it's teratogenic and carcinogenic. Surgery indicated in appearance of side effects. Follow-up should be done to diagnose neonatal thyrotoxicosis because it can cross placenta and stimulate fetal thyroid gland. And this concludes the hyperthyroidism.